Hi, I'm Dr. Paul Ruff. I'm a plastic surgeon in Washington, D.C. My practice is West End Plastic Surgery. And I have been an avid Renuvion user for quite some time. My evolution was I saw a little tiny off comment in one of our throwaway journals that piqued my interest. It was Dr. Zamora, and who doesn't love listening to Dr. Zamora? And that started my journey. And it's been a great journey. It's a fantastic technology, has clearly expanded what we can do, patients that we can treat. We'll go through that. So my topic today is techniques for success and pitfalls to avoid, and we'll just get right to it. So when I really talk about this technology and what I have come to learn, more than anything in the world, is trust the technology. This is a unique dual energy source. It is radio frequency, but most of the radio frequency devices that we've been used to using are either electrocautery, which we use for coagulation, even though this is part of the indication. This is not like our competitors, which are bulk heating devices. This is a precision heating device. It is tissue protective, and that's how I really think about it. We are trying to minimally damage the tissue surrounding the areas in which we're treating in order to optimize that contraction. And when I think about my best basic liposuction procedures, patients who may be a little bit older, haven't, maybe don't have the best quality skin before we had technology like this, when I was able to create the most limited disruption in their subcutaneous space, the retraction was significantly better. And so when I am pre-treating, tunneling, using whatever other combination devices that we use, and I think that's a big piece to consider, I try and leave that fibril septal network behind, because that's what we're targeting. We're targeting that collagen in that region, trying to couple with it, precisely shrink it down, progressively shrink it down in order to achieve the contraction and results that we are looking and should expect to achieve on a very consistent basis. And then beyond that, I really want to know what was done before in an area, whether it was liposuction, some type of surgery, another type of energy-based device, cryolipolysis, Kybella or phosphatidylcholine, anything that could create some inflammatory response, because that is going to create a fairly different collagen architecture in that region. So when we look at patient selection, I think that is probably the earliest driver of tips and techniques in order to achieve success and absolutely ensure avoidance of pitfalls. As part of the medical advisory board, I do get to evaluate a lot of different procedures, concerns that treating physicians have. And when I look at the procedures, and we'll highlight a couple of these as we go through my slides, sadly can't use pictures, but we can highlight some of the concerns and issues that we see. There are consistencies. This is not a substitute for an excisional procedure, so patient selection becomes a big one. Tissue quality, whether it's chronology or physiology, the patients who do have a fairly younger physiology, even despite their chronology, tend to have a better substrate with which to work, substrate that is better to target, as long as we have continually protected that. Older patients do respond well, though. The expectations just have to be a little bit different. Crepey skin, that's one of the difficulties. I have seen some significant improvement. I think that becomes energy-based device dependent, and oftentimes requires some other combination therapy, like a microneedling radiofrequency device up in the surface to help put that shine on the surface. As we explore other options for this technology, I believe we'll even get to up to the point where we can treat that surface skin more efficiently. So these are, examples of ideal patients. These all come from my patient database. Mid-back, flanks, fantastic. A little bit of adiposity, some mild to moderate laxity, sometimes significant laxity. Lower face and neck is excellent. Around the knees, arms, and I know we're going to be hearing a lot of different presentations today about specific treatment-related interests in these particular areas. Abdomens, My practice administrator, Deb, who you will hear from later today, she was my patient zero. And really, she had such an exceptional response, even in the face of having Ehlers-Danlos syndrome. So even things like that do not knock a patient out of a potential consideration. Times where excisional surgeries have really failed us in many ways because of the reductions or the inherent issues with the collagen in those areas. Type of anesthesia that we use. I have continually, I started doing this with mostly general anesthesia and have evolved into being able to do smaller sections, even larger sections under much less anesthesia, oral medications. But most of our patients are light IV sedation. However, we have really enjoyed the benefit of MK, or the midazolam ketamine ondansetron combination, in conjunction with local anesthesia and a little bit of Pronox. That seems to be a really spectacular plane of anxiety reduction, pain reduction in combination with the local anesthesia mixtures. So I think that has been a tremendous boom from all of our standpoints. So incision points. This is one of the common things that I end up reviewing is where we place incision points. And I like to place them discreetly, but also place them efficiently. I think this allows access without running into issues with constriction, F13 faults, extra distance that we have to travel, and then inconsistency in our treatment regions. And these incisions also have to allow us to have that gas evacuation on a regular basis. So we don't overextend that collagen and then overinflate the areas, offsetting exactly what we're trying to do, thereby having competing forces. So being able to evacuate on a regular basis. So 5 millimeters, I typically will place at least 2, if not up to 5 or 6 incisions in discrete anatomic zones in order to be able to highlight things that are more high definition or anatomy defining in those situations. Full cross tunneling. This is not, this is more about exposing the collagen in my mind, but also from a safety standpoint, allowing gas evacuation, not allowing things to build up, and once again, continuing to expand those collagen fibers that we're really looking to achieve a contraction in. And I do find, I'm a big Baser user. I've been an avid Baser user for a long time. They have these fantastic little skin ports that we suture in with a little figure-of-8 suture around the grommet. And those, I'll keep that skin open and allow really great egress of gas. So this is where I really feel like this makes a big difference. Adequate hydration of the area is a big factor in what we are trying to achieve. It allows a more efficient coupling, how this works physiologically at the electrochemical level, looking for that low impedance tissue and being able to optimize that. I'm a big fan of normal saline. I don't find that lactated ringers creates as much of a electrochemical bond between these. So I'm a bigger fan of utilizing normal saline in these patients in order to optimize that. And I use a wet to a super wet technique. I find that definitely improves that. And the biggest issue that I have noticed in my cases, in other cases that I review, is when patients have been aggressively suctioned, that putting back a small amount of solution, 50 cc's, 100 cc's, 200 cc's, for just a moment prior to treating and allow it to diffuse and cover the area again, creates a much more efficient coupling. And I think that's it. There have been a couple of high definition or pseudo high definition cases that I've reviewed where the contraction right along the etch lines has been so overly aggressive. In reviewing these, the amount of wetting solution that had been used was significantly less than what one would have expected in that situation. And then a very aggressive liposuction, which we know is going to disturb some of those fibers that we're looking to optimize or target, and then nothing going back in. Thereby, creating a connectivity and an over-energizing of the tissue. And that's really, like I said, not what we're trying to achieve. This is all about tissue protection. So Plan energy settings, I feel like we've come to refined settings. The vast majority of my patients now are treated at 75% power and 1.5 or 2 liters flow, depending on the area, the area that we open up in order to minimize that. You know, I think that is fantastic. End hits and stacking are two areas that I also review on a regular basis. I have had the opportunity to evaluate some significant thigh issues where we get severe striping in regions, and really that comes to overstacking in these areas, progressive passes in order to almost like stacking a laser pulse, which is just 100% what we don't want to do in those regions, creating a high dwell time. Unlike a bulk heating device, which only hits a very small threshold, these optimally hit that temperature where contraction occurs. And if we end up trusting that, we don't need to go back through that so many times to create a heat sink in the region. Cleaning the filament regularly, I think that leads to reduction in any desiccated tissue, any coagulum that may be left behind, that can create an inflammatory response that we don't want. And so I will clean my filaments, whether it's one of the old open hand pieces, and the only ones I really use there are the 33 millimeters to do sometimes large distances more efficiently. But I really enjoy the efficiency of the twin port hand pieces, how they move through the tissue, the fact that they have some flexibility to get us around curves and corners, specifically in abdomen, flanks, those sorts of reasons. And then treating within the same plane. I find this is probably one of the other big ones that I evaluate on a regular basis. Not moving between planes. If we're going to be subdermis, we stay subdermis. If we're going to be just above or around the scarpus fascia or the superficial fascial system, we do that, staying within those regions. I do like long strokes. Long strokes are tremendously beneficial, but then I find that sequential short strokes sometimes between my longer strokes allows me to effectively treat that area without placing too much energy back through our pivot points. And using my guide hand to direct my probe through those regions most efficiently. I think as far as what we do to undermine these areas, many of us use the Vaser. I think they're a great tissue combination. I believe Vaser at the appropriate energy levels, 70% power, 60% power, 40% power, whatever we're doing on Vaser mode. So it's a pulsed energy. It really minimizes that, but opens up through bubble cavitation and acoustic streaming multiple access to filaments without disrupting that subcutaneous layer. Because in my mind, that subcutaneous layer is like taking a carpet, which is our skin, and leaving an adequate amount there behind to compress down and create this soft, youthful, supple looking base layer that gives us that overall result. Not that we don't want a thin carpet on a concrete floor. We want something that looks supple, soft, natural. So protecting that fibril septal network through all of that. And I'm a big advocate for open and closed drainage. And I know that Dr. Zar is going to talk about some post-operative considerations, but I feel like that is a big addition, as well as performing some surveillance aspiration to remove any debris, coagulum, fluid, gas that could also potentially expand that space and become an inflammatory nidus that we don't want to have. And so this is the fibril septal network. It's everything that we look at. It's that collagen network. We see it when we do excisional surgery, and we do get these types of views sometimes when we're doing other types of surgery. So general considerations for safety, always ensure that the blade in the retractable handpiece is fully retracted before inserting into the body. That's not an issue with the twin port handpiece. Like I said, being able to navigate and move through these tissues more efficiently, I think is probably one of the best advantages of the 3 millimeter handpiece. Understanding that energy output is no different from a calorimetry standpoint than the 5 millimeter handpiece. Currently, our techniques are all activation on withdrawal. I think that is the safest way to do it. One of the things I've liked about this, and this is something that Dr. Victor Ferrari and Dr. Zamora and I came up with at a visit out to Dr. Zamora's office, is something that we call the plasmapexy. And I think it is extremely effective in many areas of the body, being able to utilize our hand, our guide hand, to put that tissue up, particularly over the obliques, on the upper abdomen, around areas of the arm, even in the flanks and back, in knee and inner thigh areas, being able to place that tissue where we want and progressively treat through layers, specifically in that region, in order to optimize the shape and contour of that area. And I have found that probably one of the most specific and successful little additions to the things that we do. One of the things that we also want to avoid is withdrawing the handpiece too close to the pivot zone. I think that's critical. It should always be in motion. Activation speed of somewhere between 1 centimeter per second and 3 centimeters per second. I'm probably on the little quicker side of things. You know, I like to ensure that we have appropriate coupling, but I'm not interested in having a heat sink. I want to, like I said, minimally disrupt or damage those areas. I want to be as specific as I can. And then I know we're gonna, like I said, Dr. Zara is gonna give a lot more about post-op considerations, but I find that these are sometimes the stumbling blocks. One of the best pieces of advice I was ever given as a resident is a perfect surgery does not mean a perfect outcome. And there are numerous points upon the recovery process that we need to optimize in order to really avoid some of those pitfalls. And those include compression, nutrition, activity, and even pain management. So I hope that was at least a helpful start to expanding your armamentarium. I know we are all advanced users, and it may seem basic to come back down to the basic level in certain aspects, but when I am reviewing cases and looking at different considerations and concerns, these are the things that consistently come up. So trust the technology, optimize your tissue space, treat with appropriate energy settings, use positioning, port sites, use your guide hand, think about plasmapexy, and you will continue to expand and improve that which you've already been able to achieve. So I appreciate your time today, and I look forward to any questions in the upcoming post-panel discussion. Thank you very much.